Hey, okay, everybody. This is Troy and Dr. Cory with Advanced Body Talk. Welcome back, Dr. Cory.
Welcome back to you.
It's a little red in the face today. We just finished a grueling workout, so if he's a little torched and I do all the talking, there's good reason for it. So, hey, last week we finished up the series on bodies in motion.
Yep.
So the reason that bodies should move, exercise following recovery, exercise routines, the benefits of different kinds of exercise. So it was a good talk about those things. But before we start, in case you want to find us, go to iTunes and search under Advanced Body Talk. And you can find us here if you're in the Medina area, here in Ohio or local. You can go to ohiopain.com or you can find us directly at 330-242-7669. So today we're going to start getting into kind of a topic-specific series here for a little bit. And we talked about bodies in motion, but now it's going to be bodies that are stuck and they have problems. So cervical disc syndrome has been kind of our neck pain, upper back pain, facet joint arthritis. It's been kind of the theme for the week, so we're going to kind of build on that. As a chiropractor, you treat a lot of that, eh?
Oh yeah, neck pain, headaches, migraines. It is extremely common. I was just at a event at the Summit County jail working with the sheriffs, and I would say 90% of people that came in there and filled out our little surveys and questionnaires of what issues they were having, headaches, neck pain, and lo and behold, most of these people were sitting at desks, working on computers. Police officers having those heavy vests on and stuff, so that forward slump posture. It's huge. It's very common, and the symptoms of it range from just simple neck tension, stuff like that, numbness and tingling in the hands, and the serious stuff. Yeah. And then headaches and migraines, and those are pretty debilitating. People think it's just a migraine is just a headache, but those are. We see patients that have them for 4 or 5 days, so 5 straight days of a headache that just puts you, knocks you on your butt. That can really shut your body down.
It's a good point that you mentioned headaches, because it was one that I was going to highlight too. Is a lot of patients are seeking care for migraine headaches or maybe tension headaches, and they see maybe a neurologist or like a headache specialist, things like this, and they're typically treated with medicines.
A big old cocktail.
Yeah, which we're not anti-medicine, but of course, it's not always our first line, and too often we even see young patients, 20s and 30s, and they're on these cocktails of medicines, and a lot of times patients don't realize that headaches are often cervicogenic, meaning that they can come from the neck. Yeah. So it oftentimes goes overlooked, but let's talk about some of the symptoms, just in detail, a little bit of the symptoms that you can get with the cervical disc syndrome. That was our big theme this week. Next week, we're going to talk about facet joint arthritis, which is a very similar problem. But this is where I think it's going to be fun to talk about this one, where there are disc issues in the neck, but then there's also facet joint issues. Maybe want to differentiate between the two, and then we'll kind of lean towards the cervical disc issues.
Well, the facet stuff, I'm just just briefly on that. When I see a patient come in, they're moving around. It's exacerbated by movement a lot. The facet joints. People think our joints in our spine are just between the discs. Well, on the posterior aspect of all of our vertebrae in our neck or our spine, there's those facet joints. They're a much smaller joint. But anytime you move, those joints articulate. So anytime you have any inflammation and arthritis in there, and there's something going on, there's small little cartilaginous lips on the end that can actually get pinched in those joints too. Any movement really exacerbates that pain and causes almost, some people classify, or they say it's almost like a little grinding or a little crackly or a creaky back and forth, almost like an old wooden floor type feeling. It's
a great analogy, old wooden floor feeling. Like when you're stepping on a wooden floor, you hear the cracks and the pops. And I like that you mentioned the little cartilaginous cap, because everybody's heard of meniscal tears in knees. And when you get a meniscal tear, it's a piece of cartilage that basically gets impinged because it's torn in between 2 bones. Same thing with facet joint syndrome. We're going to spin off on facet joint syndrome.
We'll pump the brakes on that.
We'll steer back to the other way. But it's one that really goes overlooked, and that's why I wanted to put it in next week as our theme, because everybody thinks of the spine and they go disc issues. And that's a lot of issues, but even in the lower back, if you look at the sciatic nerve can be impinged in 3 different areas for the most part. The disc, or as it exits the spine, SI joint dysfunction causes a lot of it, and then the sciatic notch piriformis complex. So looking at those nerves in a common term, and I want to talk about this one a bit today, flossing. Nerve flossing. Can you highlight on what nerve flossing is? Because it may be a new term to someone out there, but it's so important.
So when we talk about nerve flossing, the arms and legs and the most common areas we obviously perform the, not procedure, but more like an exercise or a stretch. But our nerves, obviously originate, from the brain into the spinal cord when they come out. There's a lot of different, paths they take. So through different notches in the bones, through different muscles, under different fascial planes, things like that. And at any given point, we can have any kind of entrapment.
Great point.
There's adhesions, we say, in between fascial planes, which, just causes things to not move as smoothly as possible. The easiest way I like to explain it to people is if you take two pieces of paper that are brand spanking new and rub them on top of each other, it's nice and smooth. It glides like, more knife through butter, very little friction. When we get any injuries or any kind of trauma to the body, it's like taking those pieces of paper, crumpling them up, and then, unfolding them again and trying to then, see if they can glide again. They're going to glide, but there's going to be more friction, there's going to be bumps. So as nerves travel through there, they can get caught in those adhesions, areas where there's high inflammation. So if there's any injuries or trauma, you can get scar tissue build up, those tight muscles.
Yeah.
And what we want to do is, we provide some tension and loosening to muscles via different actions of, the different body parts. So extending, the arm, extending the wrist, pulling those nerves through those areas of high tension, and then relaxing them so they, decrease the tension. So it's almost like a gliding back and forth. It can provide some relief to any nerve type pains.
Right.
It can cause, it can help break up those adhesions in those areas. So it's a way to non-invasively, treat a nerve pain without using like a surgery or medications like gabapentin, something's very common one. So it's a way that we can manipulate the body internally when it comes to muscles and nerves like that without having to be too crazy, gung ho. And it's really good with people that are really acute because it doesn't require a whole lot of motion.
Right.
It doesn't require a whole lot of force. It helps.
It helps.
Exactly.
I think a lot of patients are I don't think they've ever heard this before, and that's why really when it comes to cervical disc syndrome, a pinched nerve in the neck, I wanted to highlight this because a lot of patients come in and maybe the nerve's pinched in the neck, but we also have a real tight muscular complex here where the nerves come together as a bundle, the brachial plexus.
Yeah.
And if we ignore that, this nerve flossing really becomes a critical issue. And this is oftentimes where we win. So if you're out there and maybe you've had surgery or some kind of intervention or some type of trauma to your neck, and maybe you've had surgery or maybe the surgeon said you don't need it, but you're still having issues and you've worked on the disc and nothing's getting better. If no one's really talked about nerve flossing, this is such a key piece because we're missing things.
Yeah.
I love your paper analogy, and this is one I use a lot too, is I'll tell patients when it comes to nerve flossing on our second day as we kind of review what we're going to do with patients. Nerve flossing, it's just like flossing your teeth.
Exactly.
The piece of floss should go between the teeth, and if it's a bunch of dirt and gum and goo in between your teeth and you try to floss, it's rough at first, but then the floss should move nice and smooth.
Exactly.
And as the nerve exits the spine and the neck, it goes through this big muscle group up here, the traps, the scalenes, things like this. So we got this big muscle group, and if it gets tethered here in the spine, you can also develop some trigger points, things like this in the scalene from the nerve irritation, which then begins to trap the nerve there. So we have basically two sticking points where the nerve can be trapped. And as we work through these issues, I think what makes us oftentimes more successful is we consider nerve flossing in just about every patient.
Yeah.
So I think it's a critical piece to kind of highlight with cervical disc syndrome.
It's really important too because for us, what's really frustrating is I think one of the most overused things when it comes to the cervical spine and any kind of nerve pain is the carpal tunnel. Carpal tunnel.
Yeah.
We'll go down this road of carpal tunnel and be stuck on the wrist, the hand, the wrist. When it's like a garden hose, you got the little tiny hose at the very end of the garden, all your fingers, but it comes up from the house. So at any given point, you can have an entrapment.
That's right.
Whether the muscles, the disc, but people get on this, and some doctors will get stuck on this carpal tunnel. They'll release the transverse ligament in the wrist, and
they still have problems.
Some of them are still there.
Right.
So then we think, okay, well, is it a double crush? What we call double crush injury.
Yeah, great point.
So you have a carpal tunnel issue. But you also have an issue up here in the neck, and it's so, like I said, it's overlooked.
Right.
So from the cervical spine to those muscles, the stuff even down on the elbow. I mean, these nerves start branching off. You have, the nerves on the medial and lateral side of the elbows, different tunnels there. I mean, when you hit your funny bone, that's you hitting the nerve. So, there's a lot of different spots, and making sure we diligently go through. And I like to do it very methodically. You have a bunch of boxes, and you say, okay, check off, start from the top, start from the source, and go your way down. Just methodically do it, and go that way versus just looking at the most common. Like carpal tunnel is common. I mean, with people on computers working at desks, it is common. But opening up your eyes and having a broader spectrum versus that really big tunnel vision. Where you kind of patients pay the price for that one, and nobody wants to have surgery. I mean, those are gnarly surgeries, open up the wrist and releasing the carpal tunnel there.
Yeah.
And it could be something as simple as you said, let's just floss, get some massage therapy, loosen up all those muscles up there.
Right.
It could be something as simple as that. So it's...
I think too often too, and I never want to speak poorly of other healthcare practitioners, but this does happen frequently in the medical world. And I think that it's less common in the chiropractic world because you guys are very hands-on and great with your exams. But even we can get complacent there too at times. But too often as practitioners, we're treating tests. We're treating images of the spine for the symptom, and we're really not putting hands on.
Yep.
So I think that what you said is really important, that we're going to kind of go through these checks and balances, kind of like an airline pilot.
Yeah.
When they get in the airplane, they're not just like, okay, hit the start button, mash on the gas, let's go fly.
Yeah.
They're going through some checks and balances to make sure things are correct, and that's where delays occur. Likewise with us, we go through checks and balances, and I think the one thing that makes us outstanding as compared to other offices is the physical exam.
Oh yeah.
Going through and checking each level. So with a cervical disc syndrome, look at the neck with your hands. So look up here, feel things, look through the brachial plexus, the scalenes, the trapezius, and then, like you said, further down the arm. The nerves are just like that hose. You can get multiple kinks in a hose. And is the carpal tunnel a kink? You betcha, but there can be others.
Yeah.
And if we fail to address those, then that's when we start to see treatment failures. And it's very easy to get kind of focused on just one area.
Yeah.
But when it comes to cervical disc syndrome, I mean, there's a million different areas that this can be an issue.
Yeah. And I really like to talk about, we take pride in our physical exams. I think that's really important just because, from getting point A to point B, you got to know where you're starting.
Sure.
I've said this in previous podcasts and things like that, but knowing where you're starting. So, just posturally looking at somebody. We talk about cervical discs and, what they call text neck too. So it's our head weighs on average 10 pounds. But every time we look forward, bending forward, we get stuck in this forward flexed motion. And in posture, that 10 pounds starts to increase. 40 degrees of flexion, you're looking at 50 pounds of pressure.
Right.
Keep going further, you can get 60 pounds of pressure on that neck. And those discs aren't meant to have 10, but they're supposed to have 10 pounds, 10 pounds versus 60 pounds. So you're getting unwanted pressure on those discs. Now you're asking all the muscles in the back of your neck here to hold up your little large cabeza the entire time, and those guys are going to get super tight.
Right.
And it's the same thing for hyperextended. The muscles in the front are going to get tight. So posture is a huge thing. Just looking at it and saying, okay, this is where I'm going to start. Somebody's got a bad posture. There's a chance there's a lot of muscles up here pinching on things. So like you said, getting your hands on. It's really important to not treat an image like you said or a test, but treat the patient.
I think there's two things I want to highlight there that you hit, and I'm going to try not to forget them. But first, the tests. Tests are limited, and everybody thinks like the MRI is like the cat's meow, but an MRI is limited. And remember, most patients have problems when they're bearing weight, not when we're laying down. So an MRI is a non-weight bearing image, and this becomes even more important of the lumbar spine. So we have this non-weight bearing static image of you in one plane at that current time, meaning you're in one position. We have no idea what things are doing when you move.
It'd be nice if you could lay all day.
Right, but most patients aren't laying all day.
Exactly.
So there's no dynamic motion with the study, and there's no weight bearing with the study. So there's limitations to it. And most patients don't understand that there's 5 to 15% error rate with an MRI because of the fact that it's one still image with you non-weight bearing. So that's critical to know because many doctors don't put their hands on. They treat the MRI. So we're looking at these images on an MRI which have some variance to them. They're also slices. They also oftentimes miss things. So we're going in 3 millimeter slices. And our surgeon, Dr. Pika, picked up something the other day where we had an MRI facility that was doing 5 millimeter slices through things. And he kind of looked and he goes, wait a minute, there's something in between here. Ordered a more sensitive MRI with 2 millimeter slices and picked up a big herniation there. So there are limitations in the study, the kind of study, the magnet, it's non-weight bearing, so there's a lot to it. X-rays. X-rays are a good study, but they're limited too. And again, we're getting one static image. But the nice thing about X-rays, we can do them with weight and motion. So oftentimes the benefit of a flexion extension view goes overlooked. Many patients come to us, gosh, I've been dealing with this problem for 5 to 10 years, and they've had static images. Nobody's done flexion and extension. and there may be instability in the spine. And if you don't do flexion extension views and we're missing instability, we picked that up in a young lady, a real athletic young lady. You might maybe know who I'm talking about. She's a school counselor. Came in and she's been treated in PT and chiropractics for years with this back issue, and it's been bugging her. And we did flexion extension views, which she had never heard of, and guess what we found? A little retrolithiasis. And to you out there, that may be a big word, but it means there was instability in the spine. One of the vertebrae was shifting, and that requires us to do things differently when we see that.
I mean, it's a completely different train of thought. I mean, we always talk about getting motion. Well, if somebody's unstable, you don't want to be providing a bunch of more motion there. You want to decrease that motion, increase stability of that joint.
That's right.
So you can honestly, being narrow-minded, not doing the adequate testing, you can honestly hurt somebody.
That's right.
So it's important to make sure that we're doing the proper tests.
It's a good point, because you can make things worse. Yeah. And oftentimes we see that patients come from, and I'm not going to pick on anybody, but sometimes we see them come from other physical therapy and or chiropractic or family practice or even orthopedic offices, and they've never had flexion extension views. And that's a huge mistake in my opinion, especially if something's been resistant and or failed treatment, to not image appropriately. And I can tell you one patient who came back, and I'll never forget her, because she did have cervical disc syndrome and a headache for 182 days.
That is crazy.
Isn't it? I think you know who I'm talking about. And one of the things that frustrates me about that whole thing is there was something that occurred with several of the doctors that she highlighted to me when we first met, is they never put their hands on her. So they never did a physical exam. They were only treating these images, and she had a ton of them. MRI of the brain from these headed, looking for tumors, CTs, MRIs on the neck, discograms. I mean, you name it. There wasn't a test that was done. But no one, I won't say no one, but several of the high-level practitioners never did an exam with her. And that was something she highlighted as we took a look at things, because she needed nerve flossing. If you know who I'm talking about, all we had to do was get the nerve. It was trapped. It was just trapped. So, and being able to get that thing moving was awesome. And I think she's sending half her church at this point. If you're out there and you go to that church, you know who I'm talking about. So happy to see you guys, and happy to see you guys doing well. But it's a really, really important piece.
It is, and it's something. And I want to say with a caveat, because sometimes they say, or it's almost viewed as too important of a piece, like an end all be all. You'll see a patient that goes in and has some issues, and they have an MRI, and they have a disc bulge, but they've got no symptoms, but they want to do surgery. So are you treating the image? Are you treating the patient? If you have no symptoms and nothing's actually hurting, and this is a different issue, there's really no reason to go cut somebody.
I know we saw a guy like that,
so it's
saved, and it was, and I know you're talking about there.
So it's making sure that we're again using the images
appropriately
and properly, and making sure we're connecting with the patient, not just saying, okay, there's a bulge here, you need to go in there and cut it open, or even sometimes with chiropractic care, sometimes we'll look at them and say, oh, we gotta just, gotta keep moving this patient. Their spine's a little out of alignment here, or they're forward flex or something like that. It's not being too ambitious, but also like listening to the patient and what's going on. So it's.
You hit another thing that I'm gonna highlight these three things, and I know we're short on time already, but you use the word disc bulge, and there's a lot of confusion for people out there. Disc bulge, disc protrusion, disc herniation. Want to differentiate for me there?
There's different severities of what a disc can do. So you said there's a herniation, there's a bulge, there's an extrusion, there's a protrusion, there's a sequestration, which is the absolute worst you can have, because that's where your disc is not only bulged, but the disc material has leaked out past the actual outer fibers and is actually floating in the spinal canal. That can be something very serious.
That's a bad thing.
Exactly. So there's the simple small bulges, the small things that aren't we don't have to see any annular tears, anything like that in the actual material of the outer part of the disc. And it's just something as easy as like our McKenzie therapy can just those repetitive motions. Our discs are gelatinous. Pretty healthy discs are pretty gelatinous. Obviously, if we don't take care of our bodies, they become more firm and less mobile and stuff. But when we get to a certain point and catch it early enough, just repetitive motions and certain exercises, encouraging that disc to move back using simple physics and just the way things move, we can suck things back in. Things like spinal decompression, which is something we do here. Decreasing that pressure inside the disc to help suck anything that is slightly bulging or pushing out. You can go to things, more along the line of, protrusions, where you're actually talking about anatomical damage to the actual disc itself. So those annular fibers, those outer layers of the disc are torn. You know, that inside, that nucleus pulposus, or the very gelatinous inside part of the disc is now starting to move towards those outer layers.
Bubble on a tire.
Exactly, bubble on a tire.
Bubble on a tire.
So you got that weak outer side, and it's starting to bubble out.
Push on a nerve.
Push on a nerve. Those ones, like you said, are push on nerves because they become more severe. Those discs are pushing further out.
Right. Getting closer to herniating.
Exactly. And then we run the risk of a herniation.
That's right.
It actually blowing through all those fibers and then having a more serious issue. So it's really crucial that, you know, when we start feeling things, like, you know, we always hand these little packets, you know, 6 weeks or 3 weeks, 6 weeks through our treatment, and to really highlight some things we talk about. The biggest one I like to talk with patients about, and I'll keep bringing it up, is knowing your body and taking care of it, because you only have one go at this. You know, your body, we can obviously replace joints in our knees and hips, and even still, they're not what they were. They're titanium. It's going to move a little differently. There's a lot of things that go into that. But making sure that when we start feeling certain things, pain people think is a normal part of aging. Pain is just, I'm going to have to deal with it. It's not. Pain is an actual chemical process in our body that's triggered by damaged tissues, meaning something's not working, something's broken, something's not right. So your body is telling you, hey, something's going on. Let's get this handled. Listening to that body early on in the process so we can get a handle on things, so you can preserve whatever condition you're in and not let it progress down the line. Some people will grit through the pain and say, I'll rub some dirt on it, I'll just let it go. It's fine if you want to be a big tough guy, but then when 6, 8 weeks, 10 years goes down the road and you come in and you're hunched forward,
big problems.
Or you pick up a small Tupperware container with nothing in it and you're on the ground, you know, screaming and crying in pain, like, crap, maybe I should have looked at this earlier on, because we can, when we get things early enough, we can stop, we can still reverse some processes, but when we talk about different things of stages of degeneration, those, you know, damages to discs in the vertebra, you know, there's a certain point where you can't go back. I mean, we can restore, but really listening to the body and what it has to say is a really important process. So and it goes hand in hand with the discs, you know, making sure that if you do start feeling some, you know, some sciatic type pain, you know, pain down the leg, or you get some numbness and tingling in the fingers, you're like, crap, maybe I should just go get looked at. You know, going into a chiropractor or come in here just to do a quick exam, shoot some x-rays, just see if things are good. If you have any trauma or accidents, you know, listening to your body, because once that ball starts rolling down that hill, it sometimes becomes harder and harder to stop once the speed starts picking up. So
we are completely out of time, and we'll pick up next week. Next week we'll get into some facet joint syndromes, and we'll discuss. I'm going to bring some models in. So if you're on Facebook Live, we'll discuss some of the disc issues by looking at models. And I've got some models that show the protrusion, the bulge, and the herniation. And I think it's a good point for people to make if we're trying to educate, and it is fun to educate. So, you know, cervical disc syndromes, guys, if you're dealing with neck and upper back pain, maybe pain shooting to the shoulder blades, down the arms, numbness in the finger, or headaches that seem to generate from the back of the neck or the head, you can find more information. You can go to ohiopain.com. You can search for us there, and you can find great information on the website. You can contact us directly, 330-242-7669. And again, if you go to iTunes and you are listening to this on iTunes, hey, if you don't mind, leave us a comment, maybe a little bit of a like or even a review. Big help for us there. And next week we'll pick up. Final thoughts?
Final thoughts.
Early intervention.
Yeah.
I'll leave it there.
That's a good one.
Early intervention. If you've got problems, no problem is subtle. Oftentimes, and I saw this weekend at an event we did, we had a patient show up to a screening, and they took time out of their day to come here for what is just morning pain. Now, and that's the word I want to use, just morning pain. Because just morning pain is going to turn into something bigger.
Yeah.
So if you have a subtle symptom, easy to fix now rather than wait for disease to set in later.
And never let somebody diminish what your pain is feeling. That's that morning pain. She might, you know, it's not crazy what you would see in some other patients, but morning pain to her that's pain.
It's significant.
It's something, it's enough. So never let somebody tell you your pain doesn't matter, or it's not big enough, like, I just rub some dirt on it. Or,
so if it's dismissed, if your complaint is dismissed by another provider, reach out to us. If you're in another state or somewhere else, leave a comment, email us, go to our website, fill out a contact form, we'll reach out. So, hey, until next time, huh?
Sounds good. See you next week.